Good morning, everybody. It's wonderful to be here. It's an honor. It's an honor to represent our society, the Israel Association for Emergency Medicine. I'd like to thank Professor Hagai and Mrs. Wapner for inviting us to come and give a few words. 7 minutes on the future of emergency medicine. Well, an extra 8 minutes. Well, then I'm going to have time for coffee. The slides are on this, right? Okay. First thing I want to make clear is that emergency medicine is a public health issue. We're talking about very large numbers. We're talking about the wide end of the funnel. 130 million emergency department visits a year in the United States, 3 million in a population of 9 million in Israel. I'm sure in China I don't have the numbers, but we're talking about someplace that is where public health in its true form is practiced. And we're going to discuss some of the issues that raises. The speaker that's coming after me is going to be speaking on geriatrics. The emergency department is directly affected by and affects the care of geriatric patients, and we need to adapt to this, and we're going to see how we do that. We also have learned through various difficult lessons, especially in the pandemic time, that the emergency department is not only a place where people come and get emergent care and where major decisions are decided regarding resource allocation, but it's also a place that needs to be in constant state of readiness. In Israel, we're in constant state of readiness regarding military security issues, but also, of course, natural disasters and pandemics, as we've seen. In the past, the emergency department was a fairly low demand, low risk, low yield proposition. There wasn't a lot to be done. The present emergency department, there's a huge amount to be done, but if somebody thinks that this picture that I put up there represents any kind of an emergency department anywhere in the world, well, of course, they're mistaken. The emergency departments are in a time of crisis. If you go to the American College of Emergency Physician website, you will see national disaster, waiting times. It's not good, but we're doing so much more than we ever did before. In the future, we're going to have to figure out how to do so much more and make things and with fewer resources and in a smarter way. In the past, in the present, and in the future, there are always 3 missions for an emergency physician. The first is to diagnose and treat life and limb-threatening illness, people who are at risk of deterioration. For instance, somebody who's having an acute myocardial infarction. The second thing is somebody, maybe they're not having an actual emergency, but they think they are because they're in pain, or they're anxious, or they can't breathe well, or they're nauseated, and those need to be taken care of. And the last thing is something where we really need to pay attention going forward. It's going to be a mission. It has been a mission in the past, but it's going to change, and that is how the emergency department directs traffic, directs the patient flow of that 3 million visits a year to from the inpatient situation, from the outpatient situation into the inpatient situation, and with that, all the implications regarding care and resources. And there are times when we have a true need for speed in the emergency department. That's not going to change. In fact, that's become much more acute recently, where some of the examples are trauma, the golden hour, the patient is bleeding, we can save a life. These are patients whose entire lives are made up of what was up until today and what will be from today on. Sepsis, early recognition, reduces mortality. Early recognition and treatment reduces mortality. Acute myocardial infarction and stroke. All these things require a process, not only a technical or technological solution to keep up with the more advanced medical knowledge, but also processes that need to be put into place to allow these things to be taken care of in an efficient and safe manner. So we need immediate diagnosis for all of these problems. We need emergent intervention for all of these problems, and we need technological solutions for all of these problems. And this is where the future is going to be taking us. All of these things require not only medical diagnosis and cure, but also things like communication, logistics, and all these things need to be brought to bear upon the hub of care, which is in the emergency department. I want to use the care of a stroke patient, acute stroke patient, as a kind of an exemplar. Up until 1995, we really didn't have much to do, and we used to say that a patient presented with a stroke, our motto for that was diagnose and adios. There was not much to be done. The patient had a stroke. We were able to make a very good diagnosis about where this stroke occurred, but there wasn't much to be done. Suddenly in the 2000s, we had a high pressure, high risk, relatively high risk, but high yield intervention that we could make with the clot busting medications. This moved on in the 2010s into mechanical interventions, and perhaps we're going to see in the next decade pre-hospital treatment of stroke. So all this requires a huge amount of coordination, which is one of the emphases that I want to make, is that what goes on in the emergency department is a hub, is a nexus of care for many things, including stroke, where you have the pre-hospital EMS having to diagnose the patient, to communicate the patients where the patient is going to go, to the emergency department. Within the emergency department, a lot of technological advancements which are going to continue to progress in terms of imaging, in terms of treatment, and then finally in the neurology world where the treatments are ongoing. Now, what about moving the technology and the diagnosis and the treatment out into the field even before the patient reaches the emergency department? And here we have mobile CAT scanners. Each one of these costs $1 million or $2 million. They exist. And that's an amazing thing, but is it really amazing? I mean, I need another CAT scanner in my emergency department. So should this be out in the field taking care of a stroke patient? Well, maybe yes and maybe no, but we need to answer that question because it's a matter of managing resources. The needs are almost infinite, and the resources are not. This is a risk stratification slide. It stratifies you being at risk for being older than 60 years old. Does anybody know what this is? This is Star Trek, and what does he have in his hand, Dr. McCoy? He has a tricorder. A tricorder is a machine that you sweep over the patient, and you don't need to have the patient on a bed like Dr. Levy. You have all the information at your fingertips. Are we there? Well, we're getting there. I mean, there are so many things that have been brought into the emergency department in terms of point-of-care testing that we can make the doctor much smarter at the bedside. But we need to, even before that, use big data to tell us what is the risk, what is the patient's risk of having a certain diagnosis before we even enter into it. And that goes, and we have things like the heart score, which I can tell within a percentage to say that this patient is not going to need any kind of a heart intervention if he has a combination of things which are very low tech. Bring that to bear on our patient care flow and make a big difference in the patient's care along with resource utilization. We need to have, and we do, and we're working towards a universal electronic medical record and point-of-care testing, which I've brought a couple of examples. Soon we're going to have, we already do, there's a biomarker for head injury, which is going to limit the amount of people we even need to bring into the CAT scanner to reduce the amount of time and resources they use in the emergency department. And so we need to be sure that with the increased ability to diagnose AI, we can't have an lecture on the future of anything without using without bringing to bear the AI concept. But AI is not only going to be used in terms of a diagnosis, it's going to be used in terms of saying who doesn't need to enter into a diagnostic pathway, and that's going to save us time, money, radiation, etc. Now, we also know, and I will finish in a minute, that we need to play to our strengths. And here in Israel, there is a lot of high-tech startups. There is a lot of collaboration between industry and between government and between the hospitals. And this is something that we came out of our pandemic experience with the corona. This is a group of industry, various hospitals, Ministry of Health, Ministry of Defense, developing a technology based on radar that is focused on human beings to discover people trying to infiltrate the border, but which we are now using to get vital signs without any contact with the patient. This can be used in the emergency department on a one-on-one basis. We're working on it so it can be used in a unit or even in a mass casualty situation. And these are some of the things that we need every place needs to play to its strengths in order to advance into the future. I want to say, I'm finished, this is my last slide. I just want to say that what we need to do is we cannot forget the element of the human touch. Patients come into the emergency department, as I said, they're in various states of stress. And we're not only talking about nice to have, it's nice to be a nice doctor. We're talking about outcomes-oriented human interactions. So all the things that we're talking about today in terms of where the future goes, we need to maintain our ability and increase the ability of physicians and nurses and other staff to have the human touch. With that, I will say thank you very much for the opportunity to present.